So the patient actually came in with renal stone disease. And what I'm going to show you is not regarding his stone disease, but related to the follow-up imaging findings. So, you know, there's like a staghorn kid, well, yeah, I guess, a large stone burden, a large stone obstructing the right UPJ. So here is the axials, and I'm going to concentrate on the pelvis, which I think is, so here, you know, we see what appears to be a large prostate, okay? It's a non-con, so we can't really say much more than that. So the patient went on to get a PCNL, and then after that, the urologist did the thing and did a percutaneous nephrolithotomy, and they got a post imaging study which showed, where's my coronal? Here, which showed that the stone burden was much better. Here, I'll just do this because see, the stone burden was much improved. There's the piece, the nephrostomy tube, and this is a study that I read. Let me change it to the soft tissue window and go back to the prostate. So I read this post-op and I was confused because the Foley catheter is being displaced to the right lateral wall in what we initially thought was just an enlarged prostate. And I thought this was kind of weird because if it was a prostate, the Foley catheter should go through centrally, right?
Yeah, it already looked a little funny before the catheter was in there.
Right.
Because the bladder is kind of asymmetrically oriented on top of the so-called prostate.
Yeah, exactly. So this is what I think, Steve, you're talking about, right? It's kind of being displaced medially instead of, you know, having your typical central bladder neck. So and we didn't have any prior, you know, contrast enhanced scan, and so I said there's something here. It's not normal. The Foley's being displaced, and you know, a mass was something I was worried about. So they did a biopsy, and it came back negative for malignancy. So then they got a prostate.
That's not saying much.
No, that's not saying much at all. But the MRI says everything we need to know, which I thought was really fascinating. So any thoughts on the MR? The T2 is probably the only one that is like. It
does kind of look like BPH.
It looks like a giant BPH nodule, right? Any other thoughts?
Steve's gonna think I'm just a zebra lady, but I had a case that was like this, and it was a prostatic stump tumor.
Prostatic stump tumor.
It's a stromal tumor of uncertain potential.
Yeah, piss pump.
You can also get like GIST tumors in this location and solitary fibrous tumors. So.
Oh, no way.
You can get, so you can get like benign and malignant mesenchymal tumors of the prostate or the bladder wall.
Do they look like this, or do they have like a unique imaging appearance?
I'm kind of forgetting what a piss pump thing looks like. It looks kind of like BPH.
Oh, really?
This, has like a stromal look to it too, right? There's some kind of, like it even could be a sarcoma.
The pathology was actually came back. This is all the, this is a, you know, T1, pre-T1, and you see the hemorrhage from the biopsy. Let me show you I'm not going to show you the dynamics because there's 1,500 images, but this is the post-con, and then the diffusion is here. There. And then the ADC. Where's the ADC? Yeah. So So it was BPH, or I think it's BPH. I think that's what the path.
It's like the when we see BPH, it's often kind of lobar. You have 3 lobes. You have like left lobe, right lobe, and then a median lobe, they call it.
Uh-huh.
Sometimes it's asymmetric, but this is maybe wildly asymmetric.
Mm-hmm. Yeah, it's a very unusual looking BPH. So that's what the biopsy showed. It was a BPH nodule. So what is true about which of the statement is true? The central gland includes AFS and central zone. This is going back to the zones that Steve was referencing. BPH nodules occur in the central zone. Ectopic BPH nodules can occur in the peripheral zone, or peripheral zone is hypertrophied in BPH.
There's only one true answer. But I'm not going to answer because I'm a ringer. I'm a bit of an expert in this area.
Yes. So Steve heads the ACR Commission on Prostate. What is it called? The appropriateness criteria.
I did. I was a former sub-panel chair for the ACR GU, and we did a lot of prostate work there.
You did it for 8 years, right?
Yeah. And now we do the disease-focused panel clinical subcommittee.
Mm-hmm. For SAR, Society of Abdominal Radiology. The residents are listening. So any guesses from anyone else?
We're going for C.
C, ectopic BPH can occur in the peripheral zone. Okay, so BPH, I don't know why it has to be so complicated, but it can be, anatomy. So there's 2 major glands, central gland and peripheral gland. The central gland is divided into 3 distinguishable zones. The transition zone, the fibromuscular stroma, or AFS, anterior fibromuscular stroma, and then the central zone. This only really applies to us because we can see the differences in signal intensity on T2. I'm told by our GU pathologist when I was at UCLA that you can't distinguish any of these zones by pathology.
Yeah, they struggle. It was mapped based on the ductal architecture by McNeil, the pathologist at Stanford.
Mm-hmm.
We can see that on T2-weighted images, but unless they map the ductal architecture, the pathologist can't really see these zones per se.
Mm-hmm. So this is really something that's unique to us because neither the pathologist or the urologist care that much, but we can see these differences. So a normal prostate gland, peripheral zone is larger, and then you have the central gland, right? So you've got the central zone, the AFS, the anterior fibromuscular stroma, and then the transition zone. In older men, the transition zone balloons and then can cause obstructive symptoms that lead, typical lower urinary LUTs, lower urinary tract symptoms. So I found this really cute but helpful cartoon on how to remember the zones of the central gland. So the author of this, sorry, it's not showing the link, but I can send it to you if you guys want, to the article. He used different vegetables to help us remember the different parts of the central gland. So the carrot, C for central zone, is here. That is around the ejaculatory ducts. The tomato is here. This is your transition zone. This is where BPH happens, that enlarges in older men. And then the mushroom, the AFS, anterior muscular fibromuscular stroma, is anterior. And then potato is the peripheral zone. So that's 70% of prostate cancers happen here, but 30% will happen anteriorly. So the correct answer, this is really another interesting article on BPH, on all the different looks of BPH. And they can, so you can have ectopic BPH that herniates into the peripheral zone like this, and that's one mimic for prostate cancer because they're T2 dark like this. You see, they restrict diffusion and they enhance. Another thing that BPH, you can get this bizarre looking like nodular appearance along the bladder neck, and that you can see with granulomatous nodules that happen in people with bladder cancer that get BCG installation. So this is called granulomatous BPH. And then, Steve was referencing the median lobe. So typically, some people can mistake the median lobe, which is right here, as a mass, but it typically impresses on the bladder neck and has like a classic appearance. And then here is a nodule that's herniated. And so this is a pedunculated BPH. BPH is, to me, like uterine fibroids, for women. It can sort of like look and do bizarre things and be in weird locations. So that's one thing to look out for when you are reading these studies. So yes, Team Emery wins again, or gets this correct again. Ectopic BPH can occur in the peripheral zone. So the central gland includes the 3 zones: AFS, central zone, and transition zone. BPH typically occurs.
Sorry, I gotta mute.
Oh, that's okay. And then the transition zone is typically hypertrophied in BPH, not the peripheral zone.